Well, welcome everyone. We have special grand rounds today, the Mumford grand rounds. I'm going to turn it over to Harold Pincus to introduce our speaker and say some words about the Mumford Award. Thanks, Harold.
Hi, thanks, Jonathan. So I am delighted to introduce Kelly Kelleher as the recipient of the 2020 Emily Mumford Award. Before introducing Kelly, I wanted to say something about Emily Mumford, whom I knew and who was really an amazing woman, a real pioneer in bringing social sciences into the heart of medicine and also psychiatry. As Herb Schlesinger said in establishing this award, Dr. Mumford stressed the human side of medical care and the importance of the social and cultural context. She placed special importance on the relationship between clinician and patient and on the role of the family in healthcare. She also studied economic dimensions of health and mental health care. This lectureship is founded to preserve Emily Mumford's interest in the contribution of the social sciences in medicine. And I can't imagine a better person to receive this award than Kelly Kelleher, who is somebody who has really brought pediatrics in many ways into the heart of mental health care. It's also worth noting, just in thinking about Emily, that if you go to the Conservatory Gardens in Central Park, there's actually an Emily Mumford gate. And on the gate, on the door to the gate, there's a replica of the Emily Mumford medal that Kelly will receive eventually by mail, I think, on the door. And I urge people to sometimes take a look at that. And the Conservatory Gardens are amazing in themselves. In any case, I've known Kelly for over 30 years, going back to when he was at NIMH and then our work together at the University of Pittsburgh, along with various touch football games, tennis, and racquetball that we would get together with. We actually, when Kelly left Pittsburgh for Ohio State, we had a big party at our house, and like half the city showed up to say goodbye to Kelly. He was so much beloved. So I'm delighted to introduce Kelly. Just to say a little bit about his background, Kelly is the Distinguished Professor of Pediatrics and Public Health and the ADS Chlapaty Endowed Chair for Innovation in Pediatric Practice in the Colleges of Medicine and Public Health at The Ohio State University. He also has an administrative role as Vice President of Community Health at Nationwide Children's Hospital in Columbus, which is actually his hometown, where he grew up. He is a pediatrician and health services researcher focused on improving and measuring the quality of pediatric care for high-risk children affected by social determinants of health, as well as by violence, neglect, alcohol, drug abuse, or mental disorders. He has been continuously funded by the NIH since shortly after completing his training in 1990, and is now the principal investigator on projects from NIMH, AHRQ, and CMS and the Center for Medicare Medicaid Innovation. He's involved directly in strategy development for Nationwide Children's Healthy Neighborhoods Project, which is a healthy family zone that focuses on neighborhood leaders, community agencies, and related partnerships to improve housing, employment, schools, and safety on the near south side of Columbus. In fact, Kelly has received the Champion of Children Award from United Way in Columbus. And Kelly, really, along with his wife, Andy, and the whole family have been extensively involved in community-focused advocacy on behalf of child mental health, foster care, and child health more broadly. Kelly is someone who both talks the talk and also walks the walk in this regard, albeit with a slight limp from covering me on a pass play during a touch football game one year. So let me introduce Kelly.
Thank you, Harold, and thank you all. Yes, I have pretty much a full knee reconstruction after that game. It wasn't the first time I injured that knee, but it was the definitive time. So I'm actually very honored to be here for the Mumford Lecture. First, because I have friends that are on the phone and here, and Harold mentioned we've had a long relationship, and I truly value him as a friend. Secondly, the list of awardees for the Mumford Award is the people that I most respected in all my training and career. And so I feel very, very honored to be included in that group. It's the people that I looked up to and that I learned from. And then equally important, Dr. Mumford was a person who, Barbara Burns, during my fellowship, had me reading her papers and had me learning about the offset effect and family-centered care before we called it family-centered care completely. So it's a true privilege to be here for the Mumford Lecture. Today, though, I actually want to be a little contentious in this and say that all of that learning I did and all of the training and the research success and the continuous funding from NIH, I want to call it a failure, because I think in mental health services and mental health care, we failed the children. And I'm going to make an argument for that and call for a Marshall Plan for child development, neighborhood interventions. Kimberly Hoagwood and I have been talking about this Marshall Plan idea, but here at Nationwide Children's, I really want to tell you the story of some work here as a template for it, away from the science a little bit. So I hope you'll push me on that. I want to go ahead here and tell you that I have no disclosures except that I'm an employee at both Nationwide Children's and Ohio State and have grants from the agencies that are listed here. So what are my goals today? Well, first I want to speak briefly to the limits of traditional behavioral health services and the research on them on child development and why we have such terrible outcomes right now and epidemiology in child mental health. I want to talk about the roles of anchor institutions, and I want to list some functional metrics and goals for society and the future of our field, because I consider myself, after all these years of training, a behavioral health person. So I'm going to do that by telling you a story about Columbus, Ohio. And I know Columbus is a flyover town for all of you from New York, but Columbus actually has been doing pretty well lately. So lots of awards from the Census Bureau, Labor, Growth, Intelligent Community Year. I'm not going to read all these, but they're pretty proud of what's happening. And one of the things they're proud of is Nationwide Children's Hospital. Whether you, depending on what metric you use, it's either the first, second, or the third largest children's hospital in the United States. It's ranked in the top 5 in research funding. It's got all these other awards, whoopee, you know, celebrate. And they're serious about mental health. So what do I mean by that? Well, the Big Lots Behavioral Health Pavilion just opened this year. It's a $55 million. It's the largest new child psychiatry hospital in the United States. Has both inpatient, outpatient, and crisis services. Has extensive research floors, and it's got integrated social service agencies actually embedded in the building so that children and families can receive services. And you combine this with the largest outpatient behavioral health services any children's hospital in the United States. And so behavioral health services is valued here. And researchers and advocates like me should feel good about the commitment to behavioral health here. And of course, the area that I'm most interested in, the research on primary care integration with behavioral health. Well, NCH Primary Care has peds psychology on site. We have e-consultations and psychosocial rounds. We do education and training in behavioral health for pediatricians that exceeds the national standards for residents. And we have Physician Direct Connect, which is a phone line for emergent referrals. Any physician in our network can call on a moment's notice and be connected directly with the psychiatrist within 4 minutes. And then Project Echo, we are a regional hub for Project Echo to do distance training for primary care docs to learn about behavioral health. So Nationwide Children's Hospital has put its money where its mouth is and really taking behavioral health as far as any place I've seen. But they're not finished with that. There's also prevention. So we have rolled out Signs of Suicide, an evidence-based prevention program to stop suicide. So far, 44,000 almost students have been touched in the last 4 years, and we're expanding that to another 250 high schools in Central and Southeast Ohio. The Good Behavior Game, those of you that are familiar will know that it's a social behavioral school-based intervention to help kindergarten, actually K through 4, if you do all of it, but we do K through 2 components, and it improves grade school behavior, grade school literacy, and eventually even high school graduation, and reduces drug use in the long-term follow-up studies. And Children's Hospital has rolled out this preventive service to 2,500 students in 16 schools so far, with plans to double that over the next 5 years. So prevention is also valued here. So what does a person like me have to complain about? Well, and yet we still have behavioral health patients going up every year with psychiatric or behavioral health concerns in the NCHED. Our emergency department has continued this trend for the last 5 years, and it's going up every year, and is now the fastest growing group of patients at NCH. And this mirrors the same trend in anxiety disorders we're seeing in our primary care clinics and depression patterns that we see in our patients. So anxiety, depression, and behavioral health visits. And of course, the rate of death by suicide in the US and Franklin County, ages 5 to 19. We've made progress in Franklin County and in Ohio on almost every cause of death and serious morbidity in children and adolescents, except behavioral health conditions. And so you see here the rise in rate, both nationally and in Franklin County, with suicide, death by suicide continuing in ages 5 through 19. So as a field, behavioral health has failed to address its primary epidemics. And our research hasn't helped. Why do I say that? Well, this is a history of failure. This is my NIH RCTs just in the last 20 years. And what you see here is a list of studies, all using computers, training, motivational interviewing, referrals, quality improvement methods, and other prevention programs for high-risk kids. And they all were successful during the research interventions in improving processes of care. But our system is not designed for chronic care. And what we found out is we could change acute care processes very effectively with intensive efforts like this and research funding. But two things happen. Long-term outcomes do not change. And when the research dollars are withdrawn, the system reverts back to poor quality care. So I consider our history of $20 million here of NIH RCTs to be largely a failure of understanding what's really causing the problems here. And I think you all recognize that you have a geography chart that looks something like this. This is the Franklin County Opportunity Index map done by the Kirwan Institute. Every city has a map like this, where areas in red are considered the low opportunity indices. These were the areas that are traditionally redlined or suffered structural racism and classism to the extent that they were disinvested in. And in Columbus, we had redlining for over 85 years. And as a result, we have 7 neighborhoods that out of our 80 to 90 neighborhoods account for 1/3 of all the infant mortality, half of all the suicides, and 60% of all the gun violence. So we have concentrated disadvantage in a small number of neighborhoods in a largely minority population. It turns out 2 of those neighborhoods abut right up against Nationwide Children's Hospital. So what do we know about what happens to children in those neighborhoods? Well, development is a very complex neurobiological process. Physical and social environment interact, and we now know that it happens from before conception through adolescence and across generations with epigenetics. And so what do we see here in Columbus? Well, the thing that's been added by the National Academy of Medicine in this graphic in our report that came out this year on development of children is that not only do we understand better that it affects the nervous system, the microbiome, the endocrine system, and immune system, but that this development over time is no longer just the child. It's also the family and the community. The microbiome, endocrine changes, immune systems, these are all transmitted across communities. And we know that child development is both either positively affected or adversely affected over time. And so that translates very directly to where we spend our time. And I'm sorry for the blurry nature of this slide as I look at it now here in blown up, but up till now, all the interventions and trials are in these that I've talked about are in these top 2 buckets, clinical interventions and personal counseling and education. with good behavior game and signs of suicide starting to come in here into protective interventions. But the bottom line is none, I'm going to repeat that, none of the things we've done over the past 30 years in traditional medical settings are changing the context where individuals make decisions or addressing socioeconomic factors. And so Nationwide Children's Hospital, the United Way, the mayor's office, and a number of other people decided that we could not have 25-year differentials in life expectancy across neighborhoods in Columbus. And we did have that. In fact, the Franklinton neighborhood close to the hospital here has a 28-year difference with Upper Arlington, the neighborhood where many of our faculty live, in life expectancy. And that is too high a cost. No medical intervention can overcome that. So we decided to embark on 9 years ago a Marshall Plan for Child Development, considering the neighborhood itself as a patient, because neighborhood factors drove more of the outcomes than any biological factor we could identify. And we had a set of school partners, both elementary and high school, faith-based partner, several churches coming together into community development for all people, and public partners in United Way and the mayor's office. We also elected a neighborhood leadership academy where we train neighborhood leaders to participate in our activities using an asset-based community development model. Now, a lot of our work was built on the Harlem Children's Zone. But instead of a single building, we're talking about whole separate neighborhoods. But the hospital agreed to commit to a 5-pronged approach in each neighborhood: economic development, affordable housing, community enrichment, education, and health and wellness, if we could leverage other people's money and participation. And so Healthy Neighborhood, Healthy Families is a South Side intervention with our partnership to see what could happen over the past 9 years. Now, I can't describe all the activities in each of these zones, but I want to describe a little bit about 2 of them in particular, just so you have a flavor for what happens. Using a housing first model, we started with Healthy Homes. We have a Healthy Homes Corporate Realty, which is a not-for-profit realty agency that works with the churches and the hospital and United Way to build mixed income growth on the South Side. And in phase 1, we said we have to stabilize existing homeowners so they could stay in the neighborhood through grants to help them on the exteriors. Phase 2, we have to build structurally a housing for new families and to renovate old housing that's there. And then we start to use phase 3 to do low-income housing tax credits so low-income workers could stay in the neighborhood and not be forced out by gentrification. And then finally, phase 4, affordable single-unit scattered site rentals to try to maintain 15% of the neighborhood as affordable rentals, so we had a truly mixed income neighborhood. So the first thing we did was, Southside has a very characteristic architecture, and this is a couple examples of it, but we offer $15,000 stabilization grants for exterior improvements on windows, siding, roofs, and safety to secure people in their homes so that they don't have code violations and existing homeowners can stay. We also, in the second phase, began full gut rehabs and new builds on vacant lots for delinquent properties. And we worked with the county land bank and others who are committed to improving the neighborhood. And in Healthy Homes, we have a before and after picture as an example, but so far we've done 490 residential properties on the South Side as a Healthy Homes component. About 2/3 of these are sold to try to improve the neighborhood market, and they're sold at a loss. And we try to make up that loss through foundation gifts, but sometimes the hospital eats that money to start with. But the point is, we can't keep low-income families. This was the #1 complaint that young families had before sending their children to school in the neighborhood, was that they couldn't afford to have their children walk by the blight with all the drug deals going on. So improving the neighborhood block by block allowed us to build out from a common area and allowed school walking to increase and allowed people to stay in the neighborhood for schools and community activities. Now, what has the hospital got to do with this? I realize this is a mental health lecture and we're talking about things, but I don't think if we don't discuss how these things work in real life, we won't understand. So this is an example of a capital stack. We've had 4 of these now. We're working on our 5th. And this is a capital stack that had $1 million grant from the Columbus Foundation. And then we have different levels of debt added in. The first 2 are debt that is from Affordable Housing Trust and Ohio Capital Finance Corporation, which is most at risk if the project fails. But this Community Reinvestment Act dollars senior debt is the first paid off at the top, and that's from the commercial banks. Now they give us a 3% loan rate and now 2.5% loan rate on some of the new ones because the hospital guarantees their debt. First $1 million loss goes to the hospital, and the hospital guarantees the construction and completion of the projects. So all of these people are willing to put their money in when the right political muscle and capital from a large healthcare institution with deep pockets is willing to be at the table. We also use what's called low-income housing tax credit deals. And those of you that are familiar with low-income housing tax credit deals know that for the most part, every city gets a certain number. They are done through the State Finance Authority, through money passed from HUD. And when those happen, the developers usually work independently of each other and without coordination. And what we agreed to do on the south side was to help these developers get these low-income housing tax credits, but only in the context of working together across sites. So this example, Residents at Career Gateway, has workforce training on site to train people in healthcare careers to come work at the hospital just 2 blocks away. We have another one developed 4 blocks farther on that has the childcare site. So the low-income workers have childcare nearby. And at the third one that we are currently bidding on, we will be building a wellness center for the families to have family training, parent training, and on-site health and wellness checks. So the idea of using low-income housing tax credits in a coordinated fashion across sites was something that was very important to the neighborhood residents, and getting them access to childcare and other services in the past was something the developers had not considered. So what does this add up to? And, you know, that's fine, Kelly. Everybody's doing great business. That sounds wonderful. Well, so far we have almost $100 million in completed construction or contracted investments in the south side, where roughly 14,000 people live. And this transforms the neighborhood to the point that in the first 6 years, we did this at a loss. In the 7th and 8th years, we broke even. And this past year, we've actually gotten out of the investment part of the neighborhood, and we're only building affordable housing now for low-income workers because the neighborhood property market has tipped. So now our goal is to prevent any displacement of existing residents, and we monitor Medicaid births and number of residents in our annual household survey that are leaving the area to see if we're displacing people inappropriately. What are the outcomes? Well, vacancy rate has gone down from greater than 25% to below 6% in 2016, and that's continued to stay at around 5% this past year. And we are working to maintain a low vacancy rate because this was the #1 concern. We had the highest vacancy rate in Central Ohio in 2009, and it was only exceeded by one area in Cleveland before that. We also found out that you can't keep people in housing unless you also do sustainable workforce. And Fannie Mae helped us launch a partnered sustainable workforce where our partners at the churches, Community Development for All People, recruit people for the workforce who are interested in working. Goodwill Industry trains them, but they're trained for specific jobs at Nationwide Children's Hospital and other employers, but specifically for jobs that are open, and then coached by Nationwide Children's Hospital employees. And with this model, which is now past the Fannie Mae initial gift and is now a instituted model where all 3 agencies have decided to continue to support it, we've hired more than 1,000 workers from the neighborhood at the hospital and another 400 at other employees on the south side over the past 5 years. So overall, unemployment has declined. The number of people in the neighborhood with health insurance without health insurance has declined, and the median household income has increased significantly. It is not to the community average by any means, but it's a significant increase from where it was. So again, so far we haven't had marked displacement. We realize that's a risk, and we continue to build more affordable housing and have entry-level jobs. I will also tell you that the hospital has committed to a livable wage. So now our low-level jobs are $15 an hour at the base, with an annual increase built in for inflation. And we're seeing a lot more applicants and a lot less turnover than we used to have. And we've convinced 2 of the other hospitals to transition to that, and some of the other employers in the city. Crime is a harder measure to anticipate. In the first few years, we have not seen, we've seen a drop in crime across the community overall, but we haven't seen an acceleration beyond that until this last year or 2 in our specific neighborhood, beyond what the other neighborhoods in the synthetic controls have done. So we compared our intervention area with synthetic control neighborhoods that look similar, and show we have a slight difference compared to the rest of the city. We'll see if the fact that most of our housing has been built in the past 4 years, if that starts to improve even more or not, we don't know yet. Education was one of our commitment areas. We have a number of educational interventions. I'm not going to go through them except the one, which I think is an interesting one from those of us interested in behavioral health. Our most popular, we now have more than 400 nurses, staff, administrators, administrative assistants, volunteering as mentors in the schools that are listed here. Mentoring in the schools in the neighborhood has become an actual attractant for employees in our area. And South High School graduation rates have improved compared to overall City of Columbus graduation rates, which have remained flat. You'll see the increase here, basically from in the mid 60s to up close to 80%. We don't know if that'll be maintained, especially in the midst of COVID, but well, we hope. We are doing virtual mentoring this year instead. The Southside Neighborhood Research Project, we also survey 300 households a year. And you'll see that each year, the green on the right is the latest year. We're just going out in the field for year 4 if we can do this safely. But basically each year, neighbors felt like they were more and more members of the neighborhood. They belonged in the neighborhood. The neighborhood was a positive influence. That community spirit was trending in the right direction. That changes were positive, even for those who'd been in the neighborhood a long time, and they like to live there. So overall, the long-standing neighbors have seen it as a positive change for them. Now, Dr. Mumford was interested in the offset effect, or the extent to which improvements in health might make it, or improvements from interventions might make a difference in use of healthcare. We tried to analyze that and healthcare utilization with propensity score matching to identify 2 control neighborhoods. Our blue intervention neighborhood on the lower right, and the 2 green comparisons near west and near north. These are also areas that have had long-standing high rates of infant mortality, high rates of emergency room use, and low use of primary care. They also have very high rates of suicide and emergency room visits for psychiatric crises. I'm not going to spend time on this table and ask you to read it or go through it all. We looked at emergency room visits, inpatient admissions, and average length of stay. And basically, both our intervention neighborhood and the near north neighborhood had fairly dramatic declines in inpatient admissions and emergency room visits over the pre and the post period. No changes in length of stay during that time. The near west neighborhood did not have those similar changes. This data would not convince anybody in an academic world that there was a significant intervention effect, but it convinced a lot of the accountants and the mayor in the area and the accountable care organization to say, let's move this whole intervention effect into a new neighborhood called Linden. And 5 years from now, let's also do Franklinton. So right now, both the hospital and our partners are all planning on launching this year in 2021 into a new neighborhood called Linden and moving to another neighborhood called Franklinton in 5 more years, because they believe not just in the health and wellness effects, but the broader set of effects here. So how does this translate so that children can reach their full potential? Well, the hospital board has become convinced that we have one of the safest, largest, prettiest, and otherwise best children's hospitals, but our children are not healthy. And as a result, they feel like the combination of our neighborhood interventions expanded and our commitment to partners in the community and partnership with them should allow us to really change the health of all the children in the community. So we've adopted pediatric vital signs, and vital signs for healthcare directions was a program from the National Academy of Medicine to lay out standards for what constitutes a well-functioning health system that is both doing excellent care, but also has a healthy community. We've adapted that for children with these 8 indicators on your right. We have our partners on the left, the schools, the mayor, United Way, churches. And on the right, we have 8 indicators of child well-being, some of which appear to have very little to do with children in a behavioral health setting, almost all of which have child behavioral interventions at their roots. So infant mortality, high school graduation, obesity, kindergarten readiness, suicide, teen pregnancy, preventive care, and child mortality. For each of these, we've identified a 20% improvement between 2020 and 2030 that we seek to achieve beyond predicted trends. So infant mortality has had a declining trend nationally, but we want to exceed that goal by 20%. Obesity's had a rising goal, but we want to reduce that trend line by 20%. Suicide you saw as a rising goal. We have a plan to reduce the absolute number there as well. And in each of these, we've had to address the fact that equity has not been considered in child health care adequately. So we've always accepted the fact that rural children have worse outcomes, that Black children have worse outcomes here. For example, in infant mortality, our Black infant mortality rate is 3 times that of white children. Looking at the infant mortality rate in New Albany and Upper Arlington, 2 white suburbs, they're among the lowest in the world. But when you look at the infant mortality rate in Near East or Linden or even Southside, our infant mortality rate is extremely bad, 3.5 times. So the hospital has committed to public goals with the schools, the mayor, the United Way, and churches by 2030 to change those things and begun to invest in that. This is an example of the suicide one. We have key driver diagrams, and I don't want you to read all this or get caught up in the details, but you see on the far left here of the screen, decreasing death by suicide in Franklin County youth. This is our SMART aim. We're going to reduce the actual rate by 20% from our baseline numbers over a 3-year period. And overall, these are a variety of interventions on the far right that we are initiating and or have been initiated. They're colored yellow here because they are in process and just getting started, but the team has come together and we're working with the jails, the foster care agencies, and the homeless shelters as well. So we have just participated in received a grant from Cardinal Health Foundation, matched with hospital investment to do zero suicide training for all behavioral health providers in the county. So I want to spend a little bit of time on this slide because it's the hard parts for hospitals and health systems to get their arms around. What are the components of a Marshall Plan? And we had to walk away and decide that we weren't going to get hung up on the academics of doing this, getting way out ahead of our ability to evaluate or do research. And so the first component was the ethic, that health has to come before healthcare. I won't tell you we've won this battle in every boardroom or behind every closed door, but I will say that the board and the leadership have really adopted this mantra that health of children should come before healthcare expansion. And so we consider now every time we're building again what we should be doing. And in the era of COVID, with so much more telemedicine, it's particularly important. The equity issue is particularly salient right now, of course, but we haven't addressed the elephant. We've always accepted that outcomes are different for certain subpopulations. And that's been true since I was in training. And it is no longer acceptable to say that is an outcome that we were willing to tolerate. So we are making sure that every one of our county-wide goals that are set up on child outcomes, which all have behavioral health at their base, that we actually address the elephant and say, no, if services aren't working for a certain population, that's not the right services. And that means that we can't sit in our offices and wait for people to show up. It means we can't do things the way we've always wanted. One thing that was surprising is when we went from 1% telemedicine visits during the COVID epidemic to 30% in less than 2 months for behavioral health, our quote no-show rate went down to almost nothing. Many patients wanted to have those visits, but had barriers like transportation, had barriers at home, had barriers in childcare, had many other barriers, and we had not been willing to address the elephant in the room because it financially wasn't good for us. And now that we already know through an unnatural experiment of COVID that many families who couldn't get care before can get care, we need to do that, no matter what it costs us. We also have to consider new kinds of care and care that is more acceptable culturally. As you can tell here, we also have intensive evaluation issues. There are many design challenges. We have spent a lot of time trying to figure out how to do propensity scoring, neighborhoods that match, find other cities. In our community survey, we actually use a suburb in Cleveland that has a very similar demographic and do comparisons that way. But neighborhood evaluations, when you're using living, breathing interventions that change constantly and grow over time, are a constant challenge in evaluation. What we are seeing, though, is that schools that use the good behavior game and actually decrease some of our behavioral health referrals in the early grades. We are seeing some improvements with our behavioral health services when we train primary care providers how to use them. So behavioral health services have actually gotten better at responding as they partner more and more. And how do we design the evaluations of this in a living, breathing environment? It can't be 5 and 10-year NIH randomized controlled trials, because that's not going to be fast enough to accept this. So we have a lot of work to do in that area and design. Expansion, we know that gentrification is a constant fear in each neighborhood we go into, and we have spent a lot of time on relationship. And our relationships are longstanding, and I have several good friends and 10-year friends from working on one neighborhood that we get together every week. And so it requires those kind of trusting relationships to do that. But beyond that, people have to know that you're trying to build up the community for them and with them and as part of them, that we are no longer us and them, it is just all us. So making sure there's affordable homes and low-income jobs or get-started jobs so people can build career ladders, and they're going to have coaching and opportunity for growth. Growth also has to occur, because if this is just a unicorn and Nationwide Children's Hospital does this by itself, that's not adequate either. We really need to grow across time and have other institutions that act as anchors. So anchor institutions can be financiers, they can be employers, they can be builders and developers, they can be real estate acquisition. They have several roles to play, and each role serves a purpose in different settings. People have said, of course, Kelly, but this is a wrong time to do this. We're in a crisis. COVID is here. There are protests. The election is going on. This is not a good time. And I actually think that's not true too. Healthcare investments right now, are the large institutions going to survive? Of course they are. Are they having a bad year? Yes, and many of them are having a bad year. But there's going to be a reconfiguration, and care itself may actually get cheaper. So for example, here at Nationwide Children's Hospital, we have over 68 buildings that are a combination of research, clinical care, administrative office, et cetera. And yet most of those buildings and parking lots, even more importantly, are close to empty today. That's because we have large departments that are now wholly at home and working just fine. We have large numbers of researchers who are doing work at other places and on distance and using technology in new ways. We have cars that are not coming here. 1/4 of our visits are now telemedicine. So that means 25% of all the 1.5 million visits we had every year are no longer coming to this campus. That's fewer valet parking, that's less parking lot material, that's less administrative assistants and check-in people, that's less cleaning of staff. So we now have an opportunity to have a whole variety of real estate available for investing in our neighborhoods that we haven't had before. So new considerations about what to do with properties, what kind of benefits can hospitals and healthcare systems negotiate for investing those things in ways that will make the population healthier. We also are at a time of massive insurance surplus. So insurance companies have had a banner year. I can tell you that our accountable care organization has had a massive surplus because more than 20,000 kids did not get their well child care loan in the months of March, April, and May because of the COVID isolation. And that does not count all the elective surgeries. It does not count many other things. Will we have some rebound from missed care and some extra costs coming forward? Absolutely. But overall, the insurance industry, health insurance industry, has had one of the best profit years of all time. That money has to be invested back in health, or at least building prevention in for the future. So health promotion and future, we have to claw that money back, either through Medicaid, through the states, or through our insurance companies. And many insurance companies are already doing that. Several, for example, CareSource in Medicaid here has invested in a $50 million low-income loan fund for housing here in Central Ohio. And they intend to partner with us as a replacement for other people that have, like the Columbus Foundation, that have lost money. So overall, behavioral health services have not really done the trick of decreasing equity and reducing the epidemic that we have with behavioral health problems. And we are going to be challenged, especially post-COVID, to try to overcome the increasing losses we have with an economy in shambles, rising uncertainty, and children who are traumatized, both at home, increasing abuse and neglect. And we know that children are the longest living survivors of the COVID epidemic. So we have to find ways to build up the behavioral health services that will not require us to be at the emergency room waiting for them in crisis, but rather that will address the community needs they have and allow community resources and resilience to help prevent the problems that we've been seeing. We've tried to do that in a way in Columbus. It also matters whether or not you vote, and I will leave you with that to hope that we can do both change in our neighborhoods, change in our behavioral health services and our research, and at the voting booth. Thank you.
Thank you so much, Dr. Kelleher. That was really inspiring and really ambitious, creative work. So thank you so much for talking with us. So I'll get things started with one question. So, your work is really pushes the envelope in what we think of as healthcare. And it pushes it into domains that we would typically think of as the purview of government. And I guess I wonder how you think about that boundary, or is it even important to have a boundary in terms of what is healthcare and what is government?
So that's a great question, Jonathan. And I think what we have to acknowledge is that in healthcare, we've been greedy. we're now 21% of the GDP. And every dollar, every dollar that comes into the healthcare system, our social service spending compared to other developed countries around the world is actually, when you look at all health and social and human services, is not that different. The main difference is the United States concentrates its spending in healthcare institutions, whereas other countries around the world take the view you did and say, we're going to give this money to government and let government do these things. So as we take more and more money, and let's face it, I'm not going to comment on your institutions. I'm going to say my own institution is great at vacuuming up money. We grow every year. We have $2.5 billion in revenue every year, $1.5 million visits a year. We have a $2.5 billion endowment. And that's not unusual for the large children's hospitals. So when you have healthcare, not-for-profit institutions that are really large financial institutions controlling lots of taxpayer dollars, that is the government. And I think we should acknowledge that we all get paid very, very well to see patients who are still poor. I saw the same patients in Pittsburgh when I was at Herald in clinic for 5.5 years, and they didn't change their lifestyles, but I did. Mine got better and better and better. Theirs didn't. And so that's not the right smart use of government resources, in my opinion. So yes, this is the purview of government. Another argument that I would make here is when we take the political capital of a major healthcare institution and all its marketing department and lobbying department and everything else, we are better able to cross multiple parts of government and bring them together than anybody in the government can. And we have done that on repeated occasions where I mentioned some of the employment activities, some of the housing zoning laws and rules. So we've been able to bring those groups together. Should it be that way? No, but while it is that way, we're going to take advantage of it.
Great. Yeah, point well taken. I wanted to turn it over to Harold Pincus. I think, Harold, do you have any questions? Harold, you...
Just, I guess, this, in the chat box, there's something from Dr. Lieberman, which is the same question that I had, which is, what got Nationwide Children's to be so invested in behavioral health for kids? What was the process behind the decisions that got made? Because it's very often it's as you were sort of asserting, behavioral health is not a moneymaker for a hospital,
right?
And so what was the kind of machinations behind the scenes that actually got this to happen?
I think, like everything else, a lot of people look at this and say they're looking at a department income or a particular department resource. And the fascinating thing about our CFO here at Nationwide Children's Hospital at that time, and who's now our CEO, was that he was a big picture guy. And he said he had looked at what was happening in our accountable care organization. And so we have a $1.5 billion contract to care for roughly 450,000 Medicaid kids in Central and Southeast Ohio. We're fully capitated, fully at risk. And where are the dollars going? No matter if the kids are officially behavioral health or not, we're spending it on behavioral health. So kids with behavioral health problems had much longer lengths of stay and many more emergency department visits, even though they were officially in the hospital for a G2. Kids with behavioral health meds were the #1 cost in meds for kids increasing. #1 overall cost, behavioral health meds. #1 cost of inappropriate meds, behavioral health meds. #1, over and over and over. So the understanding that the crisis that's affecting our children right now is behavioral health, he comes to us and says, what is going on here? What do we need to do about this? Then on top of that, when it comes up in front of the board of the hospital, they said, well, how are our kids doing compared to others? And they're saying our workforces, because these are the CEO of Cardinal Health, the 14th largest company in the United States, the CEO of Nationwide Insurance, the CEO of Live Limited and Abercrombie and Fitch and Victoria's Secrets, they all sit on our board. And they said, our workforces are wreck. They've got depression and anxiety, and they're all on psych meds, and we have a lot of opioid addiction. You know, what is happening with behavioral health? And every one of them had somebody in their family who has been affected. So the board said, we have to do something. And when the hospital presented some ideas, the board said, you have to triple that investment. So the combination of our being financially at risk for this large contract, the largest contract we have, combined with a board that was actively saying our employees are growing up with all these problems. What is happening? These happened before they're young adults. So what's happening here? They all come to us on Zoloft and they all come to us on these meds, and Abilify. But how do we prevent all this in the first place? So it's been and then interestingly, once it started, it was just an unbelievable amount of community enthusiasm behind it and unbelievable support from all parties. So a lot of endorsement after that. I will also tell you that when you do something like that, you build a standalone psych hospital for kids and you invest this money, other things become easier. So the CFO said, we need employee tax abatement, so I don't have to pay employee taxes for the first 10 years while we're doing all this. The city said, sure, you build that hospital, we'll give you that, you know, and you do that, we're going to give you this. So it's not a quid pro quo per se, but it is you've been on our side and you're doing the right things for kids. We're going to help take care of you. So it involves the mayor, it involves the county commissioners, it involves the boards. I mean, it involves new developers who've come on board and said, you're building affordable housing, you're helping us get these grants. We're going to contribute to this and help you with our political muscle too. So it's all of these pieces coming together. It's not any one thing, but it requires that kind of community to come together.
Yeah, so it sounds like you've been very fortunate to have leadership with a lot of vision and foresight. The next question that we have comes from Lisa Dixon, and Lisa asks, what structures do you have to engage individuals in the neighborhood? Have you engaged police and law enforcement?
Great questions. Leave it to Lisa to hit one of the soft spots here. So the neighborhood engagement on the South Side has been spectacular, and it's been from day one. And in fact, the South Side neighborhood leadership has been at the table since the very first day, and we work with several of the churches there, and we actually run what's called a neighborhood leadership academy with the United Way. And it trains 15 residents from the South Side every 6 months, and they get trained on what's a 501c3, what's a not-for-profit, how do you run a meeting, what's an agenda, how do you write a grant to the United Way, how do you go to find out about the city council meetings, how do you all these things. And then at the end of that training, the residents are given a pool of money to do something in their neighborhood, $10,000 to invest in a project in their neighborhood. One team started up the old festival they used to have on the South Side 50 years ago. Another team set up a lost ID card service for people in the neighborhood because they knew that it's really hard to get signed up for benefits unless you have ID cards, and it wasn't something we had thought of. Many different ideas, but the point is the Neighborhood Leadership Academy has generated people who are strong enough and well-versed enough that they're learning our language and we are learning their language. So, because it really is a relationship, you are learning about somebody else and you're getting to know them, and it's the same people all the time. The police and safety people have been the hardest nut for us to crack. And I can't say why that is, but we have not had good success. We've had great success reducing crime by improving the neighborhood and investing in the neighborhood and working on a truancy program with the youth and mentoring a lot of the teenagers, but we have not made progress with the formal activities with the police departments. And a lot of same frustrations that you see represented elsewhere, I'm sure. Columbus has been spared the worst of the race issues. We've had what's called an open table here, where every fall we have open tables for the past 5 years, where people come and talk about what the race relations are like and what things need to be improved. And the Columbus Foundation invests a fair amount of money in trying to make some of those things happen. It's not where it needs to be, but it's better than it was.
Okay, so we have a question from William Honer. Any comments on the role of substance use in neighborhood health and inclusion as part of the interventions?
Yeah, substance abuse is a huge issue. You know, as you probably know, especially if you've read any of the books about the origins of the opioid crisis and Purdue Pharmaceuticals' initial marketing, Ohio and Columbus and Southeast Ohio were actually the epicenters of that. And so Ohio has second or third worst opioid addiction and mortality rate in the country related to opioids. We're seeing some improvements, and certainly some of the drug companies locally are being held accountable. What we're not doing well yet is treatment. There's not enough, and we don't have enough beds, and we don't have enough professionals. But what we're doing better is we're beginning to take care of some problems. For example, neonatal abstinence syndrome has been radically reduced because we offer reproductive choice services at the drug treatment facilities for any woman who come in and want LARC, long-acting reversible contraceptives, who want a housing voucher, who want other services, depression treatment. We will offer those services where they go to get their daily methadone or their Suboxone. We are intervening aggressively with case coordination for anybody born to a child born to a woman with substance use problems. So we're intervening aggressively there on the child side and on the adolescent side. We have several programs for homeless youth that are teenagers. Not succeeded in seeing the community come together around the adult treatment side, except around expanding facilities, which they have done. So I do think there's a lot of need for that. Again, when we are offering a lot of youth employment opportunities in IT and not just janitorial jobs and things like that, we're actually, I think we're preventing some of that. So for the next group of kids, but again, it's only been 2 neighborhoods and we're just really getting started. So I won't know in the long term for a while.
Rachel Zuckerbrot says, great talk, which I'm sure many people feel, but then asks, with improvements to individual homes and improvements to the community, individual property taxes are likely to go up, potentially to unaffordable levels. How has your program dealt with this?
Yeah, so, you know, it's fascinating because you're chasing your tail all the time on this, right? So at first, we're building all our houses at a loss just to try to get anybody to move into the neighborhood to help stabilize all the vacant properties. So we had a 32% vacancy rate at one point. 1 in 3 houses is empty. And there are some blocks that are deserted, just abandoned. And so the first thing you're doing is trying to stabilize the neighborhood. And then suddenly, after 6 years of working your tail off on that and gradually building out from a school, then all of a sudden property values flip and you suddenly have to rapidly go back and buy some of the properties you didn't develop to develop them for affordable housing. So people who are low income can stay in the neighborhood. And then you're giving homeowners who are elderly money so they can develop their properties or finish their properties because they have housing code violations and they're going to get kicked out of the neighborhood. So you give them this, but then their taxes go up. So what Columbus has done instead is to say, and it's not all the way through, it's a pilot program right now in 2 neighborhoods, that if you have been in the neighborhood more than X number of years, your property taxes cannot rise more than 4% a year. And so the idea is to have a fixed rate rise instead of the big jumps of 25 or 40% that might price people completely out. I mean, in my own neighborhood, my neighbor on the left side of me, her family has been in that house for 85 years. She's the 3rd generation living in that house. But the houses around it have continued to improve, and she is at risk of that. On the right side, we have a renter, and her rent, she's been threatened twice now to have her rent increase. So it's a constant challenge to actually watch it happen in your own neighborhood and figure out how do we stay down at City Hall enough to keep the policies in touch with where the change is happening. And right now, for example, we're working on accessory dwelling units so we can increase density without overwhelming the neighborhood, telling people it's okay, you can do limited amount of granny suites or carriage houses over garages or basement rehabs and not really threaten the quality of the neighborhood.
A follow-up question comes from Justin Smith, who asks, in regard to gentrification, has there been any concrete monitoring and data on household turnover before intervention versus during the intervention period?
Yeah, so you know, we only have a couple ways that we can monitor it right now, although we're hopeful that the census data that comes in this year will really help us once we get some of that. But we follow, because we have the Accountable Care Organization for Children, we have all the Medicaid births that are occurring in each census tract. So we are monitoring the number of Medicaid births in each area. So we know certain areas, for example, are losing Medicaid births and other areas are gaining them. We've been able to show that in the areas we've worked most intensively and preserved 15% affordable housing, because we're up to almost that much in our South Side neighborhood, that the number of Medicaid births has not changed. So the same proportion of people there living there have Medicaid or are low income. Whether or not that's true non-displacement or not could be argued. We also have a survey of 300 households in each neighborhood that we go into, that we start 2 years before and maintain. And that survey so far hasn't shown very much turnover. I think we've lost 15 families total out of our 300. That doesn't mean it won't happen. The literature on gentrification from other cities and actually the negative effects of it is pretty weak about what it really means. I mean, there are clearly a few examples around the country that weren't studied, but that were horrible because all the property was just destroyed and completely rebuilt over and everybody was kicked out. But when it's scattered site, gentrification has not really been shown, in my estimation, to have definitive negative consequences yet. But we're trying to monitor that as best we can.
There's another question from Lisa Dixon. You had mentioned that her prior question was difficult, so
He's that kind of person.
How might you build NIH funding into studying this? Do you see that as a possibility?
Well, I will tell you the thing that we're doing now is up till now, we've been basing our interventions solely on geography. And so not only when we do the housing interventions, but we do our mentoring, or we do our nurse family partnership, which is a home visiting program for young mothers that are pregnant, goes to 2 years. It's evidence-based. We try to use evidence-based programs wherever possible, but we apply them based on geography and risk factors that the programs might have. But we are bringing in now a couple geneticists to look at, can we measure epigenetics with enough accuracy to predict which premature infants are most at risk, which mothers were most unhealthy when they got pregnant. Because, for example, the Nurse Family Partnership Program has great mental health effects for mom and with regards to reduced smoking and substance use and decreased depression and good developmental outcomes for kids. And we know it's effective, but it costs somewhere between $12,000 and $20,000 per dyad because it's a 2.5-year intervention with a nurse. And we can't afford that for all the kids that really need it, all the moms that are pregnant that really need it in our neighborhoods. So we limit it, who gets it. But right now it's limited based on how many slots we have. What we'd really like to do is know which moms have enough methylation or histone formation in their epigenetics that they look to be particularly vulnerable to bad developmental outcomes for their kids. And let's do NFP for that dyad. And again, this is prediction models and how long will it take to figure that out. So I don't think we're going to have a great track record of NIH research across the whole thing. Did the neighborhood intervention work? But with regards to being able to target specific interventions more accurately, with being able to target particular outcomes, I mean, we are considering right now an earned income tax intervention for 500 pregnant women and not doing it for another 500 because of waitlist program. Could we eventually randomize that if the pilot works? Yes, and that would be an application. So again, specific sub-applications, but I don't see how NIH is ever going to say, yeah, go ahead and do as many interventions as you want in this neighborhood and not in these other two, and we'll look at that outcome and fund that. If you could figure it out, please help me. Love it.
So I think those are all the questions from the attendees, but I just wanted to check with our panelist, Harold Pincus, if there were any other questions. And if not, I will say some final words.
One question I had, Kelly, is have you looked into training sort of lay community residents in task shifting strategies to provide with supervision behavioral health interventions that would reduce access barriers and expand supply?
Yeah, we have started. So the first ones have been actually in more traditional settings, surprisingly. We use the New York State model of peer parenting. Kimberly Hoagwood trained our peer parents to come do interventions in crisis settings for families in psychiatric crisis with an adolescent. And we now have 25 peer parents in our crisis setting for young teens and adolescents in psychiatric crisis that rotate, and we've learned a lot of lessons about how to integrate them with the team. There were some early conflicts, but we've worked through that, and now they are considered an essential part of our behavioral health crisis team. They have spread to some other medical services now, so peer parents who deal with adolescents in crisis and the medical side as well. We are starting some peer groups in rural parts of Ohio and peer groups of adolescents. We have not done the structured interventions such as brief CBT that's been used in India and by the World Health Organization and other places in our rural areas yet, but I can assure you they are on the list of when we roll things out. So Project Echo is first, and we're rolling that out to primary care docs to teach them how to do brief interventions and better medication management in primary care. And then we'll be rolling out to schools and other things, ideas, because, for example, the workforce for substance abuse and depression in rural areas is almost non-existent right now.
Okay, so with that, really wanted to thank you again, Dr. Kelleher, for such inspiring work and really, I think, pushing us all to think bigger in terms of our role as healthcare providers and showing us an inspiring example of how it can be done. So thank you again. And I wanted to let everyone know that for next week and the week after, we're going to be moving from community mental health focus to global mental health focus. So next week we'll have Milton Wainberg as our speaker, and then the week after that, Vikram Patel. So thank you, everyone, and thank you, Dr. Kelleher, and we will see you again in a week.
Thank you, Jonathan.